Okay, hope this is working. So my name's John. I'm helping Armin out with this to go over question set 3. So first one, 21-year-old male construction worker presents with eye pain. So just starting with the whole exam, you can see a little bit of an injection on the conch. There's a little bit of maybe some haze versus just being out of focus, and then a little bit of stromal reaction here with a, I don't know, half a millimeter rust ring with possible foreign body within it. So first thing to do is get a history. What was going on? What got in his eye? Any risk of vegetable matter? You want to vision pupils pressure, get them dilated early because you're going to need to take a look in the back before you remove it. You want to definitely avert the eyelid on this patient. It's very easy for other small foreign bodies to get caught underneath the lid. Most common places are definitely in the fornix or just stuck to the palpebral conch. That's especially important if there's any concern for alkali burn. You should be, in that case, just getting a wet Q-tip, and sweeping the fornices. Lots of proparacaine when you're doing that. And after that, probably your first couple of times you'll want someone at least watching you for it, but I like to get a 23 gauge needle. You can do a little bit smaller. You could go to a 25. 22 is okay as well. And you're going to do this at the slit lamp. Ideally, you're going to come from temporally, but if it's accessible and you need to use your dominant hand, it's possible to do it that way as well. You can either do a burr or without a burr. Whenever most people I talk to are not using burrs down here. And so I'll pretty much just first get the foreign body plus the rust ring out, and then I'll very gently scrape the superficial stroma, the Bowman's layer, and the epithelium to try to get the bigger chunks of the rust out, but I'm not too aggressive, especially if it's near the center of the vision. You can always come back once it's kind of been pushed forward to get anything else out, and if you have to in the future, you can burr it. I always tell the patient that it's going to hurt worse after I do it than before because I've created a big scratch where it is. I always do a Seidel test after where I take a fluorescein strip, or if I don't have a fluorescein strip, then I will just use some fluoresce, gently press on the eye under the slit lamp and make sure that no fluid is leaking, just to be 100%. Okay, so number 2, 23-year-old male construction worker presents with eye pain. So this is a globe, right? There's perilimbal scleral laceration. It's a perilimbal scleral laceration, basically. Blunt trauma could do this. It's in a very suspicious spot to be probably through his wound of his cataract surgery, perhaps, although it's a little more on the scleral side than I'd expect. But that's not an uncommon spot for globes to happen, is at the point of weakest resistance, either on a corneal graft where the graft meets the host, or at another surgical site. So this is uveal tissue that's prolapsing iris plus probably a little bit of posterior tissue. So most important thing here Get the vision, don't get the pressure. Try to check if there's an APD by reverse because this one isn't really going to check very much. The most important prognostic indicator of future vision is going to be vision post trauma, so it's important to get an accurate one. In this patient, I would not dilate the eye because there's uveal prolapse, and I don't really want to mess with it. Plus, I think so. After that, you're going to do a full dilated exam on the left eye, but pretty much as soon as you see the uveal prolapse, you're going to be calling your upper level and telling, well, it's all going to be, no. Just telling them that you've got a globe. After you take a look at the eye, you get the vision, you do a very quick cursory exam, make sure that there are no other spots where the eye is open. You're going to tape some sort of shield over the eye. What I always tell patients is that the goal of this surgery is to close the eye and nothing else. We have no way of, I tell them that if the vision's good, there's a better chance. If the vision's bad, there's a very poor chance of having good vision, but that we really won't know anything until long after the surgery, and there will likely be additional surgeries that are needed to optimize vision. I think that's pretty much it for first year level. Oh, this is a patient, excuse me, a 6-year-old male with foreign body sensation. It's kind of hard to tell. It's a little out of focus, but this looks like linear streaking along linear streaking epithelial defects on the cornea. So this is very suspicious for an object on the palpebral conjunctiva scraping up and down as the patient blinks. So it's important to avert the eyelid, even if you don't see it, and sweep the fornices. Sometimes that can be a little bit difficult on the upper, so I like to use a decent amount of tetracaine for this and tell them it's going to be uncomfortable. Cover them with antibiotics after. These patients, you're going to want to do IV antibiotics. This patient, you're fine with topical antibiotics as long as they're. I generally just use Polytrim for low risk stuff, but if it's higher risk, contact lens wear, vegetable matter, anything concerning, you're going to want to just go ahead and do the Vigamox or talk to your upper level. Alrighty. So 33-year-old contact lens user presenting. Oh, excuse me. Oh, sorry, lazy Sunday. 33-year-old contact lens user presenting with eye pain, decreased vision, and photophobia. Okay, so contact lens wear, first thing you have to think of is high-risk stuff, dangerous stuff, so Pseudomonas or Acanthamoeba. So starting out, the lids look okay. This conjunctiva looks pretty hot, but not terrible. Definitely some inflammation going into the cornea here. A couple of things to note on the cornea. So there's an obvious purulent corneal ulcer here. You can see some stromal swelling, haze around here. The light reflex normally is going to be in that kind of light bulb shape. But here it's very scattered, which tells me there's a lot of corneal edema. And then you see the limbal vessels growing over, which says that there's been quite a bit of inflammation, at least for a little bit, actually. And then in the AC, the important thing to note is the hypopyon. And this is a pretty decent hypopyon. This looks like maybe 1.5 millimeters. So this is Pseudomonas until proven otherwise. You're going to be starting with fortified topical antibiotics. Vancomycin and tobramycin. The back of Will's has it, but basically, if the pharmacy needs to know how to formulate it, but usually they have their own protocols. But the back of wheels always has it. So the will says to do it alternating Q 30 minutes. Personally, I think that that's torture. So what I will do is I will do one drop vancomycin, wait 5 to 10 minutes, do tobramycin, let the patient sleep for 40 or 50 minutes. That's Q 1 hour around the clock with something like this, with the hypopion and the central involving, with the purulence. You're going to want to check them back. You're going to want to check this patient every day. Make sure that there's no signs of perforation. Perforation is going to be your biggest risk. I would tell the patient that there's a very good chance of scarring and loss of permanent vision in the case of this, and that the patient needs to take this very seriously because there's a good chance of perforating and losing the eye. Cycloplegium as well. And as this heals, you'll talk to different cornea people, but once this is large, the infection phase is responding well to the antibiotics. You could consider some low-dose steroids. Again, fortified antibiotics, Q 1 hour in a patient like this. All right, 48-year-old gardener, that's a bad sign. Presents with a 3-week history of red eye and blurry vision. Put it on Vigamox Q 1 hour by Optom 2 weeks ago, but it's still getting worse. All right, so gardener, vegetable matter, 3 weeks, didn't get better with Q 1 hour Vigamox, so either resistant to Vigamox or it's not an antibiotic, or excuse me, it's not a bacteria. So looking here, this conge is even more inflamed than this conge, a little bit, right? So this eye is pretty hot. You've got another hypopion. You have corneal edema. As you can see, this light reflex is not normal. It's pretty scattered around. Definitely have loss of iris details, especially inferiorly. And you have a very cloudy, fluffy looking appearance of this with several spots of more condensed areas. Fluffy, cloudy appearance are very suspicious for fungal infection. So this is fungal. Could this be a bad pseudomonal? Yeah. But in a history like this, especially if there's no contact lens use, this is fungal. So you need to start this patient on Q 1 hour natamycin. I would also start them on vancomycin and tobramycin, at least for a day, and then back off pretty quickly. Go down to 6 times a day on the vancomycin, tobramycin, but you want to make sure that you're not missing an antibiotic. These are hard ulcers to treat. Definitely no steroids in this early. This patient you're going to want to follow daily. You're also going to cycloplegium. Yeah, that's a nasty case. All right, 33-year-old contact lens wearer presents with the following. So, all right, what are we getting to? Yeah, okay. So, what we're trying to get at is a contact lens wearer. You always have to be suspicious for really dangerous stuff. So, in almost all patients, this is going to be herpes. That's a geographic ulcer. It's a bigger dendritiform ulcer, basically. It can be caused by zoster. It can be caused more classically by simplex. It can also be caused by acanthamoeba. So this question stem is really cueing you in to think about acanthamoeba. Again, contact lens wearers always be more suspicious for bad stuff. So with this patient, generally we're going to start so you can talk to a couple of different people about this. So Dr. Barron will say this is acanthamoeba until proven otherwise, and you need to treat it as such. Some other people might be more willing to watch it with a little bit, with treating it aggressively with Valtrex. Usually we're not using trifluridine, although some sites and cornea doctors do like to use it, especially if it's not getting better quickly on Valtrex. The problem with trifluridine is that you have to use it 9 times a day as a drop for it to be effective, which is a pretty high burden. But if you think about it, that's basically like treating a corneal ulcer, a bad corneal ulcer. Does it improve speed? Some will swear by it, and others will say it doesn't really. So that's going to be attending dependent. So this patient does look like they had acanthamoeba. So what they're getting, is getting out here is this is radial perineuritis. So this is inflammation of the corneal nerves. It's basically pathognomonic for acanthamoeba, especially if there's not a genetic problem or something with them, as some patients can present with bilateral enlarged corneal nerves. This is a very bad case. Don't know if this is actually acanthamoeba. This could be a terrible pseudomonal ulcer as well, but what he's getting at is that this ring, it's going to be a ring infiltrate with a generally clear center. This center is just melted, but this cornea looks terrible. This is an eye that's not going to, probably never going to see well again. You can tell all the corneal vascularization. This isn't going to accept a graft. But anyway, the treatment for acanthamoeba, you can get P8 chlorhexidine pretty easily. You have to get it from Patio Pharmacy here. I'm pretty sure PHMB, you can sometimes order it on Amazon, I think, but it's pretty difficult to get in the United States. So chlorhexidine is usually what we use, and we have done that every hour in one patient. Zoster, herpes, I don't know. Acanthamoeba, tyrosinemia, I don't know what the E stands for. Okay. Sexually active patients, acute onset red eye, decreased vision, purulent drainage. So this is gonorrhea. I have often thought that pseudomonal ulcers were gonorrhea because they're so purulent, but the people who have actually seen gonorrhea say that the purulence is so bad that if you wipe it away with a Q-tip and you come back a minute later, the pus is right back where you left it. So, and then Pseudomonas will have a disproportionately soupy cornea compared to the amount of purulence. So this guy gets IV ceftriaxone, and then I would cover him with, actually I don't know. Don't know which antibiotic I would use. I'd have to look that up. You would think erythromycin would be okay, but I'm not sure if you would just start Vigamox. I'd have to look that up. All right, so that's it. Thank you.